Okay, this patient with cystic fibrosis has non-resolving symptoms of lower respiratory inflammation, eosinophilia, and high IgE more than 1000. Finding consistent with allergic bronchopulmonary aspergillosis. Aspergillus species, usually Aspergillus fumigatus, are ubiquitous environmental fungi continually inhaled and cleared by natural lung defenses. In patients with structural airway disease, asthma, cystic fibrosis, recurrent infection, and mucus trapping lead to chronic colonization and hypersensitization to fungus for Aspergillus. These prompts these promotes T helper 2 based allergic response, driving production of IgE and eosinophil. ABPA may be indistinguishable from underlying cystic fibrosis, bronchopneumonia, fever, malaise, thick blood, streak, sputum are common. ABPA must be suspected if there is an unexpected ABPA must be suspected if there is an unexplained lung function unexplained lung function decline despite an appropriate antibiotic course more than 1 week. Diagnosis include evidence of Aspergillus specific sensitization, positive skin testing, specific IgE, and chest radiology showing bronchiectasis and mucus plugging intravonchial exudate appearing as tubular finger in globe radiodensities. Finger in globe radiodensity in patients with cystic fibrosis. Routine annual ABPA screening with total serum IgE is recommended. Treatment includes systemic glucocorticoid to decrease allergic inflammation and antifungal therapy, voriconazole to reduce spore burden. Okay, yes. Acute hypersensitivity pneumonitis can cause fever, malaise, pneumonia like air space infiltrate, unresponsive to antibiotic therapy. Pneumonitis typically improves spontaneously in the hospital. Patient removed from inciting exposure, eosinophilia and high IgE are not expected. Looks like C. Okay. This patient with blunt thoracic trauma, chest run over by a tractor has chest run over by a tractor has an evidence of extensive extrapulmonary has an evidence of extensive extrapulmonary leak with a both tension pneumothorax with both tension pneumothorax and crepitus. Even after appropriate treatment of the tension pneumothorax with tube thoracostomy, even after appropriate treatment of the tension pneumothorax with tube thoracostomy, there is persistent large air leak. There is persistent large air leak. This suggests continuous rapid extrapulmonary air accumulation from a tracheobronchial injury that allows, due to larger diameter of proximal airway, a larger quantity of air to escape with each breath. Tracheobronchial injury should be considered in any patient with thoracic trauma, and extensive extrapulmonary air. Bronchoscopy can directly visualize the lumen of the tracheobronchial tube and is the definitive test for diagnosis and can be easily performed through the can easily be performed through the endotracheal tube in intubated patients such as this one. High resolution CT scan can diagnose major injuries and but may miss small tears. Most patients require operative repair. Okay. Okay. So, okay. Defined Drowning, defined as respiratory impairment due to submersion in liquid, is a leading cause of accidental death in children. Children aged less than 5 are at increased risk due to around inadequate supervision around pools, bathtubs, and males aged 15 to 25 are also at high risk due to risk-taking behavior and concomitant drug and alcohol use. Complications of drowning are a result of hypoxemia from fluid aspiration. The aspirated liquid washes out pulmonary surfactant and increase alveolar capillary membrane permeability, which can lead to development of non-cardiogenic pulmonary edema, respiratory insufficiency, and ARDS. Signs and symptoms of ARDS, dyspnea, wheezing, crackles, cyanosis typically begin within the first 8 hours, and respiratory insufficiency can progress insidiously over 72 hours after an initial event. Therefore, despite currently being asymptomatic, this patient is still at risk for ARDS. All patients with non-fatal drowning event, even with normal vital sign and examination finding, should be admitted to the hospital for cardiopulmonary monitoring for at least 8 hours. In this case, the patient has an excellent prognosis because he was submerged briefly, resuscitated quickly, and is now back to the baseline. Okay, is it hypersensitivity pneumonitis? Okay, this patient with recurrent short-lived episodes of sudden onset fever. This patient with recurrent short-lived episodes of sudden onset fever, non-productive cough, and dyspnea most likely has hypersensitivity pneumonitis and exaggerated immunologic response to an inhaled antigen, mold, bacteria, animal protein. The condition has a variable presentation, acute or chronic, that likely depends on the dose and chronicity of antigen exposure. Acute hypersensitive pneumonitis classically presents with recurrent episodes of abrupt onset fever, non-productive cough, dyspnea, and fatigue that coincide with intermittent high-dose antigen exposure developing within hours of exposure. Hypoxemia is common and fine crackles are present on lung auscultation. Leukocytosis is also often present. Chest X-ray may be normal or can reveal scattered microalveolar interstitial opacities that typically resolve between episodes. The condition is often mistaken between bacterial pneumonia and is treated with antibiotics. However, acute HP self-resolves within several months. Acute HP self-resolves within several hours to days After removal of the antigen exposure, long-term management requires consistent avoidance of antigen often which can often but not always be identified with a detailed occupational exposure history, farming, textile. Okay, yes. IPF, idiopathic pulmonary fibrosis, presents with gradually progressive dyspnea, cough, fatigue, weight loss. Intermittent short leave would be unusual. In addition, IPF typically affects patients age more than 50, and influenza pneumonia can present with symptoms and chest X-ray findings similar to acute HB. However, recurrent disease that presents abruptly resolves within 1 to 2 days is not consistent with influenza. Mm. He, there is metabolic acidosis, isn't it? What is your diagnosis? His urine output is very low, so or to 100 ml, so his kidney is dying. Is it hemodialysis? It's normal. Yes, that's the interesting part. It's either A or F. I think so. Yes, it's neither one. We are roaming around wrong direction. He is in shock, and we are not ready to give fluid. He is lack of urine. We should give fluid first. It's a common sense. Yes, we missed. This patient has likely developed. This patient has likely developed pneumonia, has signs of septic shock, fever, tachycardia, hypotension, poor urine output after securing an airway if needed. The goal is managing septic shock. The goal in managing septic shock include restoring restoring adequate tissue perfusion, and identifying the underlying infection and treating it appropriately. Crystalloid solution, normal saline lactated ringer, is the fluid of choice to restore blood volume quickly, as it is effective as albumin in terms of survival, but is less costly and easier to acquire. Crystalloids are Crystalloids should be given IV bolus to improve systolic blood pressure more than 90 mm mercury, at which perfusion is considered adequate. There is continued with close monitoring for evidence of volume overload, pulmonary edema, hypoxia, or no fluid until fluid no longer improves the blood pressure. If if the patient fails to respond or develops evidence of volume overload without improvement in blood pressure, then vasopressor norepinephrine should be started to improve perfusion. This patient's arterial blood gas is suggestive of a compensated metabolic acidosis, likely lactic acidosis, due to organ hypoperfusion. Therefore, it would be reasonable to administer isotonic saline without concern about worsening the acidosis. Yes, yes, she smoked half a pack of cigarettes daily, and reversibility test is negative. Lava Lama. This patient has significant smoking history, chronic lower respiratory symptoms, and irreversible airflow obstruction. These findings are consistent with COPD. Uh, Although pulmonary function tests are crucial for COPD diagnosis, FEV1 is not a primary consideration for guiding therapy because it correlates poorly with treatment response. Instead, sedation, selection of initial bronchodilator therapy for stable COPD diagnosis on the following two dimensions: symptom severity, graded using validated instruments, COPD assessment test that measures disease impact on daily life, dyspnea during light housework, and exacerbation risk assessed by the frequency and seriousness of acute exacerbation of COPD. Higher risk, one or more than one hospitalization, or two or more than two outpatient exacerbation requiring use of oral corticosteroid at home manually. Patients are uh, classified into group A, B, and E based on following factors. For patients with more severe symptoms, group B, such as this patient who has dyspnea with even light housework or more frequent serious exacerbation. Group E, preferred initial therapy includes a daily inhaled long-acting beta-2 agonist LABA, formoterol plus long-acting muscarinic antagonist LAMA, tiotropium. Combination LABA plus LAMA therapy maximizes bronchodilation, stabilizes against bronchoconstriction, and reduces mucus hypersecretion. For patients with low symptom severity and low exacerbation risk, Group A, an inhaled short-acting beta-2 agonist SABA or SAMA is used as needed. Such patients tend to have early COPD with intermittent mild symptoms, unlike this patient who has persistent dyspnea interfering with her daily activities. Okay.